This is an odd time for teaching and learning, but definitely those who are serious in starting the practice for refractive correction ICL, they all are there. And I welcome you all. And so before taking you further for the introduction, um, you are present here. So do you practice refractive surgery? Uh, all of you? Good. And how many are doing ICLs? Okay, good. So that is nice. So ICL is something which has changed the surgical correction platform of the refractive correction is there. So I will be starting with this, and together with me will be Dr. Partha Biswas, Dr. Ramamurthy, Dr. Mahipal Sachdev, Dr. J.S. Titial, and Sudhang Bharti. They all are going to come soon, and then we all are going to have discussions on each part of the instruction, the surgical steps. So I will start my talk. Is it ready? Introduction, and so before I take you further, I introduce myself. I'm Purendra Bhasin, and I have started practicing surgical correction almost 22, 23 years back, and I started doing phakic lenses with the very size lens way back, almost 19 and a half years back, and for last 17 years I am practicing this. Please come over here, Dr. Ramurthy. Yeah. Is it coming? Please come on the dais, Dr. Ramamurthy. Ramamurthy is from Coimbatore, and he is the pioneer surgeon in doing phakic lenses of our country. And he has got tremendous experience, and he will be tremendous experience of variety of lenses which are available in Phakic IOL platform. So I welcome you, Dr. Ramurthy. So coming to the introduction, and various refractive procedures are available. I will be focusing on the surgical part, and there are two types of surgeries which we can do. One is the corneal-based surgery, and other is the lens-based surgery. So corneal-based surgery is excimer laser, surface procedure, and smile. इधर नहीं है, इधर से बंद हो जाएगा. अच्छा. One second, sorry for the interruption. So we will be focusing on lens-based procedure, and that is the phakic IOLs. And so a phakic IOL is an intraocular lens which is implanted in front of the natural lens of the eye, and it is meant to correct the refractive error. So these are various kinds are available, maybe angle supported phakic IOL, iris fixated, or the posterior chamber phakic IOL. So we will be focusing on the posterior chamber phakic IOLs. So the quest for this started since 1986. Variety of lenses have been developed and implanted. The very common and popular one was VeriSize, which was made up of PMMA, large incision, disenclavation, damage to the cornea, all these were there, and variety of lenses were available. The first prototype of the present day foldable soft phakic lens, which is placed in the sulcus, was done by Fyodorov in 1986, and which was made up of silicon material. So, to take you further, a simple video how it is done, then we'll be discussing on rest of the things, how I do it. So I make a 3 mm incision, which is a roomy incision, but it doesn't induce any astigmatism, which the tunnel should be 1.5 mm, and lens is loaded, and it is then placed in the anterior chamber, and it is unfolded slowly on the surface of the iris, and then with the help of the spatula, you can tuck the 4 haptics, this is a plate haptic lens, in the behind the iris in the sulcus, and remove the viscoelastic with the help of whatever is your choice, by either Simcoe cannula or bimanual or coaxial irrigation aspiration. So the advantages of corneal refractive procedure are that it preserves the corneal integrity. Unlike the corneal based surgery, the structural integrity is maintained, and it is particularly beneficial for thin or irregular cornea, steep cornea, or chances of ectasia if it is there, and which make them unsuitable for LASIK or surface corneal procedure. The other advantage is the reversibility. It offers the unique advantage of being reversible. Anything which happens in the due course of time, you can easily explant this lens and perform the rest of the surgery, whether it is cataract, whether it is ICL exchange, or anything. And it can correct a wider range of refractive error, right up to, with the Indian lens, you can correct up to -30 diopters also, and including very, very high myopia or hyperopia, and you can correct the astigmatism also up to 6 diopters. Since these procedures do not involve altering the corneal surface, they are less likely to produce dry eye, and because the nerves are not damaged, and which is a common side effect of this. And then it provides the anatomical advantage. As it is placed behind the iris, cosmetically it is better, far from the endothelium. There is no damage to the endothelium, close to the nodal point of the eye, so there is a gain in the retinal size image and the better quality, and we all will, you all will agree that we see there is an increase in the vision in the post-operative period in high refractive error cases. Sulcus, it is located in the sulcus, which is a stable location which allows the toric design to be implanted, easily removable, exchangeable, it's a reversible technique, no fixations into the tissue, does not alter shape or remove the tissue, it's unlike the cornea-based procedure. Coming to the availability of the lens, the best and the foremost in the league is the Star Surgical Vision IOL. I don't have any financial interest in any of this, and they are available right from +10 diopters to -18 diopters, and we can correct cylinder up to 6 diopters, and they are available in various sizes right from 12.1, 12.6 to 13.2, and rarely 13.7 or 13.6. And it is made up of a polymer material. And then Care Group comes out with the IPCL, which can correct up to from +15 diopters up to -30 diopters, and can correct 10 diopters of astigmatism. Their size can be varied from 0.25 millimeter variation, and they can be as small as 11 millimeter to as large as 14 millimeter, but it is made up of hydrophilic acrylic material. Then Appasamy comes up with their RIL, same +10 to -23. And another good lens is iCryl from Biotech, which comes from 0 diopters to -23 diopters with a 0.5 step, and the sizing is from 12 to 13.5. Rest of the lenses, except the ICL from Star, which is made up of polymer, other lenses are made up of hydrophilic acrylic copolymer material. I will focus on this. Coming to the ICL, which is made up of 60% of polyhydroxyethyl HEMA material with the 36% of water content, and it is made up of porcine collagen. And there is a central vault. Now, vault, as you all know, it's like a hump in the center, which accommodates the convexity of the natural crystalline lens, so that the lens doesn't touches the crystalline lens. This lens doesn't touches the crystalline lens, and there is a space in between. So it is made up of a foldable material. It absorbs UV radiation, but the problem is the sizing. So we have to be very careful in measuring and going further. This material, collamer, attracts the fibronectin, and it repels the proteins. So the proteins doesn't deposit on the surface, so the material remains very clear, and it is not recognized as a foreign body, unlike the silicon material. And because of this, the maximum light transmission is there, better optical performance, excellent transmittance, and there is a less glare and halo phenomena. Coming to the design of this, it is from the ICL V4 family with a central port of 360 micron, which equates the aqueous from behind the ICL and in the anterior chamber. And this eliminates the need for the iodotomies. As you can see here in the center, there is an opening. And for redundancy and for the removal of the viscoelastic, there are two extra ports on the other side, and it equates the aqueous, and with this, the recent study says the chances of cataract formation is also decreased. With the newer generation Vision ICL, the optic size has been increased to 6.1 millimeter, which is around 7 millimeter at the level of the cornea, and in 0.5 to 14 diopters. And this reduces the glare and halo phenomena, and in larger pupil, which is commonly seen in young myopes, which is very beneficial to these patients, especially during the night driving. As I said earlier, it is available up to 6 diopters correction of the astigmatism, and from 0.5 to minus 18 diopters, and from plus 0.5 to plus 10 diopters. Coming to the IPCL, which is from the care group, it is equally good lens, what my experience is, and it is the other popular posterior chamber phakic lens. It also treats high degree of emmetropia. It is made up of reinforced hybrid hydrophilic acrylic material, and there are 6 haptics, as you can see here, and there are 5 holes in it, and to equate the aqueous, and central hole is of 380 micron, and there are other 6 holes on the side. And as I have said earlier also, it has a vault, which is very, very important to be recollected and remembered. And advanced versions are available now for correction of the presbyopia. The EVO Viva ICL, which is based on EDOF principle, and it is now available in our country also. And IPCL also comes with a presbyopic lens with a refractive-diffractive optic profile. With this brief introduction, I go to my next talk, if